I have a few announcements I wanted to make before we started with the presentations this morning. If any of the Medical Advisory Board doctors are here, we're going to start that meeting at 8 o'clock tomorrow morning. Doug, have you heard this? No. Okay, there's going to be a meeting of the Medical Advisory Board and the TMA Board at 8 o'clock tomorrow morning, somewhere around in this area, so...
Can I just say I vote yes?
No, you're going to have to be there, I'm sorry. And nobody's leaving that room without getting assignments, so it's really going to suck. It occurred to me sometime over the last few days that there may be people here who are not members of the Transverse Myelitis Association. There are brochures on our table out in the hallway out there. If you would pick one of those up, I think there's an explanation on here about how to become a member. There are no membership fees to become a member of the association. You get a newsletter twice a year, unless Pauline and I are having our house remodeled, in which case I miss a newsletter, which is what's going on right now, which is why you haven't had one for a little while. And you get a membership directory and you get connected into this network. So if you aren't, and there are physicians and PTs and OTs and all sorts of other medical professionals who are members of our association, I would encourage you to join. And I also want to put in a plug for the Connors cookbook that's sitting out there. The Connors did a really neat thing. They collected recipes from members of our association from all around the world, and they put together a recipe book that was composed by people who have transverse myelitis who submitted favorite recipes. So I would encourage you, and all the funds go to the Transverse Myelitis Association. Our Kathy, is Kathy Duro? Kathy, why don't you stand up? If you are a parent of a child with TM, please find Kathy if you're interested in talking to another parent in the next couple days. Kathy's one of the leaders of our parent group, and I would encourage you to find her. Do you want to introduce Chitra?
Yeah.
Oh, I also might mention, at the end of today's schedule, there's an hour set aside for question and answer. We're going to do that tomorrow morning. Instead of, first of all, that hour isn't going to be there because we're all going to run late today. And then Doug is going to be doing his presentation at the end of the day, and he's just going to continue on and summarize for us some of the science that was done over the last couple days so that we can all get some sense of what sorts of topics they were talking about over there.
So just one more plug there. For those of you who have heard about Project Restore, we have shirts available. Carlos, will you stand up? Carlos has been kind enough to model that. Oh, Mike Fitzgerald as well is modeling the shirts, and so they're available out in the lobby. Okay, so we're going to start with Chitra. Many of you know Chitra. She's been the program coordinator for the Transverse Myelitis Center. She's going to tell you about what's been going on over the last couple years.
Before I start, can I make a quick announcement? For people who want CME credit, please turn in your evaluation and self-credit form to the registration desk today if you're not going to be here tomorrow. And I know the form says it's for licensed physicians. Those who are not physicians or PTs, OTs, RNs, you get the full credit, whatever the sessions are worth, both science and clinical. Okay, I'm going to talk today about what we've been doing at the Transverse Myelitis Center here. I'm going to go through the first 3 slides really quickly because we're going to talk in detail about these studies later today. Both Dr. Kaplan and Doug will tell you more about them. As most of you know, the Johns Hopkins TM Center was established in October 1999, and in keeping with the tripartite mission of Hopkins, we focus on clinical care, clinical research, and basic science research. And you have seen the multidisciplinary nature of this center. You've heard from urologists, you've heard from psychiatrists. Our basic research focuses in 3 main areas. Developing an understanding of the neural injury in TM through the creation of an animal model, and understanding what is the role of inflammation, what happens, what leads to paralysis, and using neural stem cells to become motor neurons. And you will hear in great detail about this later this afternoon. In our clinical research to date, in 2001, when we had our Baltimore Symposium, at the end of it, we formed a TM consortium working group. Many of the physicians are here in this room today. At the end of that symposium, we got together and we wrote this uniform diagnostic criteria for TM, and this was published in 2002. You've heard about that from Doug, but I will quickly recap them. So there were 5 basic criteria that we came up with to say this is TM. The first was you have neurologic symptoms attributable to the spinal cord. They're bilateral signs and or symptoms. You reach the rapidity of progression of this disease is between 4 hours and 21 days. And there are signs of inflammation. Many of you in this room have gotten an MRI, and you get a gadolinium dye when you get the MRI. The dye picks up inflammation and enhances in an image, and that's a sign of inflammation. And then you get a lumbar puncture, and we look at the cells. And if there are more white blood cells than what is normal, we say you're inflamed, or an elevated IgG index. We've used these criteria, and we've sort of developed a clinical database of all patients we've seen over the last 4 years, since October 99. We have about 500 of them. I've tried to analyze the data, and I will show you some of it after the slide. We also have a clinical repository of serum and spinal fluid to go with the clinical data so we can draw correlations. Many of you asked questions about what is the role of vaccination in TM. And you've heard from Dr. MacArthur how exacting clinical trials are. They take so much time to put them in place. There's so much bureaucracy to start them. We're going to start a retrospective study. It's in the final stages of being approved by our institutional review board. And it's going to be a fairly large study to see, is there a difference between neurologic patients who are not TM, those who are TM, and non-neurologic controls? And is there a difference between the incidence of vaccination prior to the onset of symptoms? It's very important to learn about biomarkers of injury because they're very objective measurements to define the illness. And there are 2. There's one, actually, we've been studying in great detail about the IL-6. And Dr. Kaplan and Doug talked about this in the science, and they will recap it for you today. You heard from Doug already from Adam, about study of cognitive dysfunction and depression. Okay, so now onto the data that we've seen, epidemiology and clinical characteristics of TM. So we've seen over 500 patients. When I analyzed this data, it was about 4 months ago, so there were 354 patients at that time. And we took all patients who came with acute non-compressive myelopathy, and we said, let's see how many of them meet the criteria for TM. We found that 60 of them, 266 were TM patients. 5% of those patients were defined as MS when they came to us. 20% of them had non-inflammatory myelopathies, which means they didn't meet any of those criteria for inflammation. 75% of them had inflammation, which was localized to the spinal cord, and they met the criteria for TM. Of them, 64% were idiopathic. What do I mean by that? There was no known etiology, no underlying cause for what their disease was. 24% went on to present as recurrent TM. This sounds like a high number for people who went on to become recurrent TM. So I should tell you up front that being a tertiary care center, our referrals are biased, and we see cases that are probably more severe than others do. 8% were associated with some systemic inflammatory disease. We found that there were no more males than there were females. The mean age of onset was about 35 years. And about 27% of them were below the age of 18 years. And you heard from Dr. Pidcock when he sort of showed you the data on those 47 patients, with pediatric TM. And we followed these patients for an average of about 5 years. This is just a graph to show you what the age distribution is. As you can see, there are 3 peaks. There's one between 0 and 5 years. We saw a higher number of patients. Between 10 and 15, and between 40 and 50, there seemed to be a higher incidence of patients with onset of TM. Okay, this is a busy slide, but I'll run through it, hoping you will understand. The first part shows, okay, we asked people, okay, so did you have 30 days prior to the onset of symptoms any vaccination? Did you have any illness? Did you have any trauma? And this was the first 30 days. So we found that about 13% of the patients reported an antecedent vaccination at about 20, 22, 24 days prior to the onset of symptoms. About 62 out of 163 patients, about 40% of them reported antecedent illness about 24 days prior to the onset of symptoms, and another about 20% reported trauma 10 days prior to the onset of symptoms. So each one of them had something that they could go back and say, well, this happened to me, and then my symptoms started. When we looked at what percent of the patients had weakness in their acute phase, we found that about 80% of them said that was my symptom. But the symptom that topped it all was numbness. About 90% of them said, you know, that was my first symptom. We all had numbness. There was pain in about 70% of the patients, and bladder dysfunction in about 70% of the patients. We also wanted to see how quickly did the patients from the onset of symptoms reach their worst. And as you can see, there is one bar that stands out, and that's 1 day. So about 40% of the patients reached their worst within 24 hours. They were paralyzed for some people, that was their worst. For some people, it was just sensory deficit, that was the worst. We looked at ambulation in the acute phase, and I've marked HFDS. I mean, I'm thinking most of you saw Dr. Pidcock's talk. Hughes Functional Disability Scale was used in Guillain-Barré, and it's a very simple motor function scale. It goes from 0 through 6. 0 is normal, 4 is when you're bed-bound or wheelchair-bound, and 5 is when you need ventilator, and 6 is death. As you can see, this graph curves to the right. There were more people in the acute phase who were either wheelchair-bound or bed-bound or worse. We looked at the CSF characteristics of patients, and we found that there was an average of about 38 cells in the white blood cells, the normal 0 to 5. Protein levels were about 75 grams per deciliter. IL-6 was a marker that we looked at, which you will hear in greater detail today, and we found that it was elevated. Normals are like 2 picograms per mil. The mean was about 516 picograms per mil in these patients. 1433, this is a marker of neuronal injury that was published by Dr. Rani and Doug, and 42% of them tested positive. 1433 is a marker that we think predicts poor outcome. Okay, so we looked at the MRI, and we said, okay, how many people had a lesion in the cervical cord? How many people in the thoracic cord? Not much difference, 44% and 37%. We looked at the extent of lesions. For some people, it was one segment. For some people, it went all the way through the entire spinal cord. And then we looked at the clinical sensory level. And we found that there is a difference. Majority of them had a clinical cervical level in the thoracic region of the spinal cord. We looked at the treatments received. The number one treatment received was IV steroids. Some folks received IVIG, acyclovir, which is an antiviral therapy, and plasma exchange. So after following them for a mean follow-up of 5 years, we looked at the outcome, sensory and autonomic, and a good amount of patients were still left with pain. It was 75%, it came down, but 40% are still left with pain. Numbness was 90, it's reduced, 75% still left with pain. A good percentage of patients are still left with urinary urgency and catheter dependency, although a lot less than before. And now if you see the graph on motor function, the graph moves to the left. As you can see now, there are not that many people who are wheelchair-bound or ventilator-dependent, sort of getting towards the normal, being able to walk with some sort of assistance. So does anything impact outcome? I've shown you all this data. What does it mean? We found that age at onset of disease perhaps impacts outcome. If you got TM when you were younger than when you were older, probably it predicts a different course. Maybe because when you're young, your immune system's more active, you have a more fulminant illness, Probably when the immune system crosses into the central nervous system, it attacks more. How quickly symptoms progress is also, sorry. How quickly symptoms progress was also an indicator of, as a prognostic factor. We found that the people who progressed their symptoms really quickly, within 1 day, they tended to do worse, maybe because they had a worse acute illness. Gender. When we looked at follow-up, we found that what percent of the men continued to be wheelchair-bound compared to women? More men do. 32% of the men continued to be wheelchair-bound or worse than women, and this was statistically significant. Sorry. No? It's okay. Thanks. We looked at catheter dependency in the acute phase. Yes, worse outcome. The odds of someone having a worse outcome was 3.2 times higher if you were catheter dependent in the acute phase than not. Treatment. I will show you the next slide. Okay, this is a little complicated slide. If you've seen the posters yesterday, you may have seen this. So we looked at people who got IV steroids, plasma exchange, and Cytoxan. Went back retrospectively to see was there any difference in outcome. And we said, okay, this was their baseline. Okay, what percent recovery did they have compared to their baseline? So if their baseline was, say, a level 2, and they went down to a 4, did they come back to a 2? And what percent of them came back to a 2? And we find that those who got Cytoxan had the largest improvement compared to IV steroids or plasma exchange. Okay, so what's recurrent TM? Many of you are concerned, will I get it again? Okay, I think you should take it. Thanks. You can just not answer the call, just leave it, thanks. What percent of them are recurrent TM? So what is recurrence? We define recurrence as being different from MS and being different from DIVIX, as being another insult, another injury to the spinal cord, a second attack. Okay, were there any predictors of recurrence? Can we tell early on, will you get it again or not? Multifocal lesions. If there seem to be lesions in the spinal cord that are more than one, we tend to say, there is a possibility that you will get this again. Maybe you will go on to define as MS, maybe you'll become DIVIX, maybe you'll become recurrent TM. Also, recurrent TM patients tend to have oligoclonal bands in the CSF and an underlying mixed connective tissue disorder. We also found this autoantibody, serum SSA, and people who are positive for this seem to be at a greater risk of recurrent TM. Okay, so what do all these numbers mean? So TM is a group of disorders with different causes. Patients with TM improve from the acute phase, but they are left with significant disability due to weakness, pain, sexual dysfunction, bowel, and bladder. Certain factors help us predict who will recover completely, but this is our database of 170 patients. I'm showing you what we found. This needs to be done on a larger number of patients to see if we can generalize this. And we must diagnose patients with TM more efficiently and develop more effective treatment strategies. I think that's where I am. Do you have any questions? Sorry. It's okay. I apologize.
All right, any questions? Yep.
If you develop recurrent TM, is there an average time frame in which you will see your next recurrence?
So the question was, if you had recurrent TM, is there an average time period during which, a window is what you mean, when you can recur? If you've not had another episode within a year, we don't think you recur. We have not seen anybody who's gone out a year and then had recurrence. Oh, sure. Jesse?
What is the Cytoxan that you showed? There was a slide that had IV steroids.
Plasma exchange and Cytoxan. Good.
Cytoxan, the other word for Cytoxan is cyclophosphamide. It's a very aggressive immunosuppressant. It's actually a chemotherapy cyclophosphamide is even more aggressive. So what we've begun to do is if people come in and are in the acute phase but aren't doing well, I mean they're not responding in a day or two to steroids, we often will consider cyclophosphamide, and we've had some success. I mean, it's still small numbers, but some people do very, very well where they had not been doing particularly well to just steroids alone. And so the notion is that the cyclophosphamide was better at just quieting down the immune system very, very rapidly.
Are emergency room doctors aware of this treatment?
The question is, are emergency room doctors aware of cyclophosphamide? No. No. It would almost never be given in the emergency room. It's a pretty big deal to give it. You've got to do a lot of hydration. You've got to watch for bladder toxicity. So it's kind of not really the front line. It's got to be, you know, once somebody gets in, an experienced neurologist would do that. Question is, how long after the onset would you use cyclophosphamide, right? You want to answer?
No.
I'm hogging the microphone. Well, it's really kind of a revved up steroids. So it's got to be done in the inflammatory phase. Earlier is probably better. So certainly within the first, week is what I would say. Beyond that, your inflammatory aspect is declining, and so there wouldn't be as much rationale to use it. Yep.
I had cytoxin and ACTH 4 months after the onset of my recurrent, and it got me back walking again.
Is that right? So now recurrent TM is obviously a different thing. We've talked about transverse myelitis as a monophasic event, but that's kind of a lie. I mean, you all know that, and we showed that 24% of patients actually recur. So in those situations, we often will use cyclophosphamide at the very beginning of recurrences for exactly that reason that you mentioned. And there are several ways that you can give it. You can give it as a pulse intravenous infusion, or some people will be on pill form. So, for recurrent transverse myelitis, the concept is that there is recurrent immune activation over time. So how do you quiet that down? Well, there are a series of pills that you could take that kind of modulate that. I'm sure you've heard of many of them. Imuran, or azathioprine, methotrexate, Cellcept is another one, and cyclophosphamide is another one. Yeah. Right, that's an excellent question. I mean, defining recurrence is not trivial. People will note that there is fluctuation in symptoms over time. Sandy, you probably get this very frequently. Is this a recurrence? I'm feeling a little bit worse, maybe more fatigued. Sometimes symptoms are exacerbated by heat. And the question that is really critical to define is there recurrent inflammation? Because that really defines a recurrent attack. It's got to be new inflammation, as opposed to, people with transverse myelitis are more susceptible to fluctuations for reasons that we often can't understand. A cold will wipe you out. I mean, you kind of not yourself for weeks on end, whereas other people would probably bounce back. So that can occur. And yet that doesn't necessarily mean that there's a recurrent inflammation. So, what we often do, and we're probably more aggressive about this than anybody else, is if we think it is, we really need to define if it's inflammation, right? So we'll repeat the MRI or even the spinal tap, because if there's inflammation, we know what to do. If not, we can start to sort out those other things that cause fluctuations. Question?
What percentage of ADM have recurrence?
ADM?
Well, it depends who you ask. Sorry, you're right. I should repeat the question. What percentage of patients with ADEM, acute disseminated encephalomyelitis, recur? Some people would say 0. You know, the distinction, as you know, of transverse myelitis from ADEM is that transverse myelitis is localized to the spinal cord, whereas ADEM is brain and spinal cord. But ADEM is typically a monophasic process. And in fact, most people would think that if ADEM does recur, this looks a lot like multiple sclerosis. Peter, what would you say to that?
I would agree with you. I think sometimes
at the time of presentation, you really can't tell. Some people think that there are characteristics on the MRI that would distinguish ADEM from MS, but the reality is that many times patients get called ADEM and then we'll see them back 3-6 months later and they have a second attack that we define as MS, and so in retrospect, they probably weren't ADEM, and so it's almost a semantic argument. But in general, of people who get called ADEM, my experience, maybe it's biased because I'm an MS person, is that about a third of them end up getting MS.
So let's move on. I mean, we're here all day. We'll do this kind of all day as new questions come up. One of the questions I did want to raise is that if ADEM recurs, many people obviously think this is multiple sclerosis and should be treated. Recurrent transverse myelitis, you heard from Dean Wingerchuk, and I agree, and Peter agrees, interferons and those types of things for recurrent transverse myelitis typically aren't the most effective treatment. It's those pill forms that I told you about, which we believe are actually more effective. So, all right, so let's move on. Who's speaking? Okay.